Imagine that you are the healthcare provider in an outpatient office, in our outpatient office, and you're caring for a patient by the name of Jane. Jane's a 36-year-old female. She has a history of opioid use disorder. She also has depression, anxiety, and night terrors. She started taking prescription pain medications when she was in a near fatal car accident. And this was several years back. She suffered a multitude of injuries, had lots of surgeries, lots of postoperative complications, and was appropriately placed on prescription pain medications. And as a result of that, after years of being on them, she became dependent on them, developed addictive behaviors around them, and then eventually, when she was no longer being prescribed them, she went to the streets to get these prescription medications. This is a common story I'm sure you've all heard. And in her case, she had, started using heroin and fentanyl on the streets. She had a strong family history of addiction. Her sister actually died of an opioid overdose. The only thing that came out of that that was remotely positive was that it urged Jane to go into treatment. She went into residential treatment and then a halfway house, and then ultimately ended up in outpatient treatment. So you are her provider, and she has lots of services that she's getting through your medical clinic. So she's doing intensive outpatient treatment, which is about 3 hours a day, 3 to 4 days a week. She is also getting individual sessions. She sees the psychiatric provider, and she also sees the medical provider. She's on buprenorphine, a life-saving medication used in the treatment of opioid use disorder. And one of the issues is that although she's doing really well in treatment, she lives in a rural community, and she has to drive an hour every day to and from all of these appointments. And she's averaging about 12 appointment hours a week. So what essentially happens is she comes to you and says, I can't maintain this anymore. I've kind of run out of favors. My friends and family can't do this anymore. And you have two options. This is obviously a telehealth conference, and we're talking about telehealth here. But in the state of Pennsylvania, telehealth was not always a definite option for the medical providers to offer her. My name is Julia Diallo. I'm the Chief Medical Officer of Gateway Rehabilitation Center. We are one of the largest nonprofit providers of substance use disorder treatment in the state of Pennsylvania. We are located in southwestern Pennsylvania. We have a fairly large physical footprint. We take care of a lot of patients. We have just under 600 residential beds. We have 20 facilities of varying different levels of care across a full continuum of care. And we have about 1,000 outpatients, which includes telehealth and in-person. We also are proud to have a Center of Excellence in Opioid Use Disorder in the state of Pennsylvania, one of the first and one of the best. In our residential treatment, we provide the highest level of care, which is like a detox or withdrawal management. We have co-occurring programming, which takes care of people with substance use disorders and mental health disease. We specialize in adolescent care as well. In the outpatient setting, we provide all levels of care, in addition to medications for opioid use disorder. I'm proud to say that the majority of our patients with opioid use disorder are on life-sustaining medication, buprenorphine, and in our residential facility, we take patients on methadone as well. We offer a full continuum of care because addiction is a chronic disease, and you cannot treat addiction with a single treatment episode. So it's not like strep throat where you give antibiotics and then it goes away. And so telehealth is really, really effective in the treatment of substance use disorder because people need to access care over very long periods of time. And for some, this is over a lifetime. So for some of our patients who are in more of an urban setting, it's convenience or ease of use, but a lot of our patients, even in urban settings, don't have transportation and things. But in the rural setting, for Jane, this is literally a lifeline. So for her, she either gets treatment via telehealth or she gets no treatment at all. So Jane is our patient, and we have many compelling stories of heroes just like Jane battling this disease against all odds, and telehealth is helping us do this. So I want to talk a little bit today about our journey with telehealth. We're relatively new to the field, but we are advancing quickly and expanding quickly. So it all begins with our mission, and our mission is to help all, not just people who live close to our buildings. And our promise is our community drives our cause, and we're committed to responding to the needs of our region. And we believe that telehealth will meet these needs. So in the beginning, before COVID, we barely did any. We did some audio-only stuff. COVID thrust us into telehealth, just like lots of other healthcare providers. And it worked really well for us. The telehealth flexibility has really made it easy. But once telehealth was over and we knew that our patients, the feedback from our patients was that they felt connected, they felt cared for, they were more comfortable in their homes, and they wanted to continue it. We knew that our treatment would be audited. We would need a audit trail, timestamps, things like that, and that we had to become more sophisticated with how we would deliver this care. As an executive team and our board of directors, we decided that we would invest in this strategy to reach more patients. And so we recruited a director, Matt Rumbaugh, who came with work experience from GE and the University of Mississippi, one of the two HRSA-funded centers of excellence in telehealth. We invested in a sophisticated platform, which we are always developing to meet the unique needs of our patients. We invested in IT infrastructure across our relatively large physical footprint, and we built a telehealth team. I would say one of the most compelling things that we've done that's been very useful is our digital coordinator. Our digital coordinator, it really helps with the digital literacy of our patients. So she helps the patients download the app. She helps them to learn the functionality of the app, turn on the notifications. She will test broadband and connectivity issues, and she does that with every single patient. We therefore can anticipate issues before the actual appointments occur, and she'll even do testing before the appointments occur. We also have a telehealth line that could be called any hour of the day or night, and our telehealth team will pick it up. And that's for support before, after, during appointments. We developed a hybrid model. We built our telehealth model exactly like how we were doing in-person care because we knew our in-person care worked well. So as we're using telehealth in our residential and our outpatient setting, some legislation is passed in Pennsylvania, making it a lot easier for us to do it. So Senate Bill 739 passed in 2024, and basically what this gave us was payment parity. And so I think a lot of people involved in telehealth know what this is, but in case you don't, this essentially means that telehealth care in Pennsylvania is now required to be reimbursed as if care was rendered in person. And of course, this is important for a nonprofit like Gateway Rehab, who takes care of all people who come to us, including those with nothing, and we provide a tremendous amount of charity care. It's very difficult to implement and further expand telehealth without reimbursement and sustainability. So this was big for us. Telehealth isn't free. You know, the platform is very expensive. We use a device called a MedWand, which looks like we use a lot of different tools, but just to give you some examples, the MedWand is a device that looks like a computer mouse, but it allows us to do a full virtual physical exam. So I can have a medical provider at one site, but I can provide medical care at all other sites using this technology. It's very important. We use Rehavior, which is an AI integrated health information modifier tool that's embedded in our platform. And for us, doing telehealth and having it reimbursed was just an absolute necessity for us to be able to continue to do it. So this was big for us, the passing of this bill. And then more recently, In May, we were really excited to be granted the first telehealth-only license by DDAP under the leadership of Governor Shapiro. What they did was they converted a physical license at a site and gave it a telehealth exemption so that we can provide telehealth at that bill out of that site without providing patient care at that site. And our plan at that site is to build our telehealth hub. Because we have built an enterprise model, we need a hub to house this infrastructure, to house our team, to perform trainings, and offer trainings to other providers who we want to teach how to do this the right way, because we believe that we're doing this really well. So the other thing that this really does for us is it's difficult for us to provide in-person care and bill out of that physical space, and also bill for telehealth out of that physical space. Beyond the scope of this discussion, but basically for our data analytics, and we want to give data back to the payers, but it gets very confusing for us when we're providing telehealth care out of this physical site and physical in-person care out of that site. It's a lot of administrative burden. And this telehealth only license will reduce that significantly for us so we can spend less time on that sort of thing and more time just taking care of people. So we have some work to do with the payers. I'm happy to say this is going really well. In fact, today, just this morning, we were contracted with one of the largest Medicaid providers of patients that we take, and that's really exciting news for us. But we have some work to do with the payers and with the single county authorities. As you may or may not know, patients who enter into treatment for substance use disorder, if they don't have any insurance, they're usually funded by the county first while we apply for Medicaid. And so we work with a lot of different counties. There are 63 total counties in the state of Pennsylvania, and we want to work with all of them so that we can provide telehealth anywhere in the state. So some considerations that I want to just talk about today are broadband issues. Many rural areas still face broadband issues and will continue to. Even us, some of our locations are in rural places, and we even have network issues as a result of that. Our patient-facing clinical app connects via cellular networks, which is helpful. And we do telehealth assessments on every patient that are one-on-one, and we deal directly with whatever issue they have before they even start their appointment. And we found that to be very helpful. As we all know about the public library programs, we are hoping that that becomes an option for our patients who are in rural areas. Partnering with these libraries could enhance our home and community services. As far as digital literacy is concerned, our digital coordinator really takes the lead on that. And our telehealth line is used a lot by our patients. They call it all the time, and it's always answered. Streamlining our workflow is also something we focus on because we developed this hybrid model and we want it to be easy for people, and we want it to be modeling after in-person care. So we're always trying to enhance that and reduce redundancy in everything that we do. And from a technology standpoint, we determined the need for an enterprise solution. So we went with a platform that could support our whole organization called MCare. Our training is pretty straightforward, thanks to Kathy. And Matrix, they provide all of our certified training, including our competency and compliance and risk management. We're proud to say that all of our staff have been trained, and we have a lot of employees, hundreds of employees. While we seek additional funding for our telehealth hub, our program is not grant dependent at all. We've invested to ensure sustainability through reimbursement alone. Establishing county contracts and contracts with payers will be something we need to continue to work on. And in this current political landscape, there's certainly some uncertainty around that. So more to come on that. We collect lots of data, which I'm happy to discuss, but I don't want to take up too much time here. But just to mention a few, we look at length of stay, compliance metrics, communications via encrypted messaging. Our patients send hundreds and hundreds and hundreds of messages back and forth. It's really awesome to see it. And that's the connection that makes the difference. When someone feels, I'm having a craving to use, they can message their provider, and their provider can intervene It's very effective. I can't speak to it enough. We look at patient adherence, all kinds of things. So Jane is doing well. It's a happy story. Jane is doing well, and this is actually a quote from her psychiatric provider, which I'm going to read. I think we would have lost her, Jane, if not for telehealth. When she started, appointments were in between diaper changes and chaos at home. Now she has been sober for over a year, is in a relationship, and was able to move to a better school district for her kids. She describes her life now as fulfilling, and this is certainly the best she has felt in the past few years. So today at GRC, our Hope from Home telehealth program is so much more than the audio-visual Zoom call that we did during COVID. And we're really proud of that because we know that the secure patient portal that we use, the journaling that our patients can do, the interactive app, the encrypted messaging, all the things that come with a really sophisticated platform that's needed in substance use disorder treatment. I mean, this is done in other fields of medicine. Why isn't it done in SUD treatment? Because substance use disorders are devastating diseases. We've all been touched by them personally, I'm sure. And we need more of this. So I do really want to give a shout out to our state and the legislators of our state for making these bold legislative moves to allow this to be easier for us, to reduce the administrative burden on us, and to allow us to more easily reach the patients that need help. And with that, I will say, you know, our heroes are our patients. They inspire us, they drive everything we do. And we, as an organization, are grateful for them. And we're very grateful to be in this fight side by side with them. And we're committed to offering them the best of anything we ever can. And we believe telehealth is really going to be key here. So thanks.